Thank you so much to the organizers for inviting me to speak to this fascinating meeting. And the first three talks have been terrific. And I hope that we can continue the dialogue at the end of my talk. So what I'd like to do is, first of all, disclose my conflicts to you, and then start off with the basics. When we approach a patient with acromegaly and we're really trying to personalize the treatment for that patient, the most basic question is, what's the cause of acromegaly? Because all acromegaly is not the same. And really what I'd like to do is divide acromegaly into three categories: primary growth hormone excess, primarily from a pituitary tumor; extra pituitary excess of growth hormone from ectopic production of growth hormone, which is extremely rare; and finally, GHRH excess, growth hormone releasing hormone excess, which may be derived from a tumor of the hypothalamic region, or more commonly from a carcinoid neuroendocrine tumor. And the majority of patients with acromegaly will indeed have a pituitary adenoma. And there are multiple forms of pituitary adenomas, and we don't really have time to go into them now, but it's very important before you start treatment that you understand the etiology on the pituitary side in this blue box, which is determining your patient's syndrome, because treatments will be different for each of these subtypes of pituitary causes of acromegaly. Very, very rarely, you may encounter a patient with a pancreatic tumor or a lymphoma with ectopic growth hormone and a normal pituitary. And then, of course, the patients with ectopic GHRH production are usually those with quite evident carcinoid syndrome, accounting for the vast majority of these patients. And then there is a new one, which I've listed in the middle here as iatrogenic. The new cause of acromegaly is patients abusing growth hormone. And I'm sure that you, especially in the big cities, encounter patients who buy growth hormone illegitimately or illicitly for athletic purposes. Doping in our athletes is very common with growth hormone, and also trying to reverse the frailty of aging inappropriately. And we've actually had patients who are presenting with acromegaly, as exemplified in this case over here, by abusing growth hormone. So the message from this slide is, before we can embark on a personal approach to acromegaly, we have to understand the etiology. Regardless of the etiology, the impact of growth hormone and IGF-1 excess is quite negative. Patients develop hypertension, cardiomyopathy, and valve disease. Cerebrovascular accidents and strokes are not uncommon. Gonadal dysfunction occurs. There are hard, bony changes of the teeth, which you're all aware of, and what's become more evident today are the presence of vertebral fractures, as exemplified in this patient, which may be asymptomatic and undiagnosed unless you look for them. Soft tissue tumors, especially in the colon. Diabetes for two reasons: because growth hormone impacts the pancreas directly as a target for the hormone, and also growth hormone acts at the periphery to block insulin action. In fact, growth hormone itself is one of the most potent blockers of insulin signaling, and that may be one of the reasons why we encounter women with gestational diabetes, because of the powerful anti-insulin action effects of growth hormone. Sleep apnea occurs because of the soft tissue swelling in the airways. And then don't forget in the center that this compressive mass is going to cause hypopituitarism as well, if the underlying pituitary function is in fact attenuated and compressed by the expanding mass. So these patients have a very, very broad spectrum of comorbidities. And I just wanted to give you one example, which was beautifully exemplified recently, of a patient exhibiting both the hard, bony changes exhibited in the maxilla and teeth, as well as the soft tissue changes in these large, large polyps and swelling of the airways, which exemplifies both the soft tissue swelling and the hard bony changes in the same patients. The most important concern why we have to focus our treatment and optimize our treatment is the fact that these patients, if untreated and uncontrolled, have accelerated circulatory deaths and accelerated cerebrovascular deaths. So that is our clinical challenge. So how do we approach them? We approach them by eliminating their morbidities, reducing mortalities, and we're going to talk a lot about enhancing their quality of life. The strategies that we're going to have at our disposal today have to be safe. We should aim to control the mass effects, to control growth hormone secretion and action, but at the same time to make sure that we're preserving underlying pituitary function. And we assess them by, in the main, long-term by age-adjusted IGF-1 levels and improved comorbidities. So this is the background context of an approach to personalized therapy. So let's start with a patient, with a person, an individual. This is a young, newly diagnosed acromegaly patient. She presents with excess sweating, jaw prognathism, headache, arthritis, and hypertension, and her IGF-1 is clearly very, very elevated. And there you can see her tumor, which is lifting the optic chiasm on the north, and on the east and the west, she's invading the cavernous sinus. This is a macroadenoma, hypersecreting growth hormone. She's sent for surgery, and 24 hours after resection of a sparsely granulated growth hormone secreting adenoma, her random growth hormone is still high. It's 2. It should be less than 1 randomly. 6 months later in follow-up, her IGF-1 is still elevated, and at that point, somatostatin receptor ligand SRL therapy is initiated. So this is the patient. How do we offer her a personalized approach to her management? Well, we have 6 or 7 markers which we can utilize today to determine for us some inklings of the beginning of a very, very well thought through approach to personalizing our management with clear biomarkers for outcomes to these patients. Hormone granularity is one of them. So whether the granularity of the tumor is sparse or dense in terms of growth hormone granules will be an important biomarker of successful outcome or not. The presence of a specific receptor on the tumor, SST2 or SST5, the 2 somatostatin receptor subtypes, or even the dopamine receptor. The intensity of the MRI may also be a determinant, a biomarker determinant of responsiveness to treatment. The age of a patient will be a determinant, will be a very important biomarker because younger age patients do poorly, whereas older patients do much better in terms of their outcome. Cell cycle markers are important, and it's important to get this from your pathologist because the presence of a high Ki67 or a P21 will be a portender of a poor outcome. And the presence of cell-specific transcription factors, and the one for growth hormone, which is the most important one, is PIT1 or PU1F1, is very well established today, and the pathologist can stand for it, but it's not much help in your decision-making as a biomarker for therapy. Tumor proliferation is very important. The tumor size and the tumor invasion is going to be an important biomarker in determining your personalized approach. And finally, although the mutations are very well characterized, and Dr. Corbonitz, who spoke to you earlier this morning, was really one of the original discoverers of the AIP mutations in these patients. And the earlier studies on the GSP mutation from Italy, from Anna Spada, all are very, very important in terms of characterizing the phenotypes of these tumors. But at the moment, the application to long-term therapeutic outcome is as yet unclear in the sporadic non-familial cases. So let me give you an example of taking those biomarkers and putting it in the context of 2 patients. This is on the top, we have a patient who is relatively middle-aged or old, depending on your age. For me, she's young. For many of you, she will be old, but you can see she has a small tumor, characteristic of the elderly patients. She has a microadenoma, densely granulated with growth hormone granules, and you can see the growth hormone granules here densely packed in the microadenoma as compared to the younger patient with a large invasive macroadenoma, sparsely granulated, and you can see on EM over here, she has these sparse growth hormone granules, and the phenotypic outcome is different for these two categories of patients. And post-surgical disease persistent will be more prevalent for the patient with a macroadenoma, the paracellular extension, the younger age, the higher IGF-1, and most importantly, the choice of the neurosurgeon, with neurosurgical experience being a significant, statistically significant determinant of outcome. Not the expertise of the neurosurgeon, because all neurosurgeons who are qualified are experts. It's the experience in operating on pituitary tumors. And we've taken all that information and we now categorize our patients into three types, type 1 through type 3. Type 1 being those with the small microadenomas, and type 3, the large invasive macroadenomas. The microadenomas are associated with dense granulation, no invasiveness, and in contrast, the type 3 are the patients with the macroadenomas, sparsely granulated, and the immunoreactivity for Ki-67 is high. 42% of our patients with type 3 have a Ki-67 greater than 3, whereas 90% of those with type 1 have a Ki-67 of less than 3. Indicating low proliferative activity. The biochemistry is also different in that the type 3 patients have higher IGF-1 levels, whereas the type 1 patients have lower IGF-1 levels. Type 3 patients may require more than one surgery and sometimes more than 2 surgeries. They require very, very aggressive therapy, and ultimate long-term control is achieved in the minority of patients with type 3, whereas there is frequent control achieved in patients with type 1. So take the patient that I presented to you. She clearly fits into type 3. She has a large, aggressive, sparsely granulated macroadenoma. Her outcomes are going to be adverse despite more treatments because she is so young. And therefore, she requires a very, very focused, aggressive, personalized approach. And we have tools today which can enable us to offer her an optimal outcome for her disorder. So obviously, the first tool we have is the consultation and the expertise of our neurosurgical colleagues, either for microadenomas or for macroadenomas. However, the advantages of surgery, the rapid growth hormone decrease, the one-time cost, the potential cure, and the debulking to enhance subsequent adjuvant medical treatment have to be balanced with the disadvantages. And the most important disadvantage of surgery is that tumor persists and the growth hormone hypersecretion persists, just as it did in the patient that I showed you. Patients are at risk for hypopituitarism, and not all patients with acromegaly, especially those with florid disease or the more elderly ones, are appropriate candidates for surgery. The risks of surgery are well known to this audience. There are overall complications, diabetes insipidus, especially transiently, may occur. Electrolyte abnormalities, neurological deficits, and CSF rhinorrhea occur postoperatively. And unfortunately, this is a general anesthesia. So like for all surgeries, there is a small, but definite, very small risk of mortality. The more complications occur in those patients with more comorbidities, and again, to re-emphasize, the surgical volume is a very, very important determinant of reported complications. So what about the medical approach? Well, the medical approach is based on our underlying understanding of the pathophysiology of the disorder. So growth hormone releasing hormone derived from the hypothalamus and ghrelin derived from the gut act to induce the somatotroph to produce growth hormone, whereas somatostatin acts to suppress growth hormone production by the somatotroph. And somatostatin signaling to the pituitary is mediated by receptors sitting on the cell surface of the somatotroph cell. And the one that we are most interested in is SST2, and less so, but still very important for therapy, SST5. And these two receptors sitting on the somatotroph are important determinants that have been exploited for therapeutic purposes. And the ideal is to change the pattern of acromegalic growth hormone secretion you can see on the right over here, which is erratic and wild, to that of the normal patient on the left shown, where there's normal growth hormone secretion with a burst of growth hormone mainly occurring at night and flat or undetectable throughout most of the day. Very, very rarely do we achieve recapitulation of the controlled growth hormone hypersecretory pattern. And because these patients' tumors express SSTR2 and SSTR5, the availability of a somatostatin agonist, a receptor agonist, is exploited to suppress growth hormone. The original work from Steve Lambert's, and I hate to think that it's so many decades ago now, 1985, showing that if you actually inject somatostatin analog, you will suppress growth hormone compared to placebo within 2 hours, and growth hormone will remain suppressed before it starts rising slowly. And the patient's soft tissue swelling, as exemplified in this patient with a macroglossia and a tracheotomy, is resolved within 16 weeks. So this is the application of the understanding of the pathophysiology to a personalized approach to a patient who does express predominantly SSTR2. In the USA today, we have available several drugs. We have 4 somatostatin receptor ligands. Lanreotide autogel, which is given 60 to 120 every 4 to 6 weeks subcutaneously. Pasireotide and Octreotide LAR, which is given Q4 weekly. And oral Octreotide, which is given 40 to 80 milligrams daily in capsules. We also have available the dopamine agonist, cabergoline, which we give 1 to 4 milligrams orally every week. But I must say, I won't talk much about cabergoline because our experience with cabergoline is very, very dismal. We don't achieve success with cabergoline in our patients. And if we do, they require very high doses, and patients are usually quite nauseated. And then we have available the other class, which is the growth hormone receptor antagonist Pegvisomant, which works predominantly on the liver to block IGF production, in contrast to the SRLs, which work predominantly on the pituitary tumor to block some growth hormone secretion. However, none of these available medications, even if we're going to be personalizingly focusing them on the specific patient, are disease modifying. They all require lifelong application. We can individually titrate these patients, and I'll show you some examples, or we can combine them with each other in order to achieve optimal therapy. And we have to tell our patients that this will be lifelong therapy. So the question that we're all asking is, how effective are the somatostatin receptor ligands in terms of their efficacy in suppressing IGF-1 and suppressing growth hormone, regardless of which one of those 4 ligands that we use? And overall, we did a meta-analysis of all studies, controlled and uncontrolled, patients who had been selected or unselected for their trials in the literature, all published through 2014, and most of this data holds up today. Overall, about 60% of patients will exhibit controlled growth hormone as defined by that study, or controlled IGF-1 as defined by that study. There will be several patients in the upper right-hand quadrant in whom you will achieve universal control of their growth hormone and IGF-1. And there will be patients in the bottom left-hand quadrant of each graph who you will not achieve universal control. And this is the overall meta-analysis of the worldwide literature, which holds true today. So having said that, we now have availability of a new approach to delivering octreotide to the pituitary tumor, and that is using oral capsules. And the oral capsules contain the same octreotide. So whatever I'm going to talk about oral application now, it's the same octreotide that is in the injection, acting on the same receptor as the Lanreotide in the Lanreotide injection. All it is a capsule with combined surfactant and an oily suspension, mainly of fatty acid, to provide a transient permeability enhancer, a TPE, which is safe, which transiently opens the tight junctions and enables octreotide to enter the systemic circulation without chemical modification. And the first phase 1 safety trials in human volunteers show that if you look on the left-hand panel over here, that if you give an oral capsule of octreotide, you can measure basal growth hormone over 2 hours and show in the red that basal growth hormone is suppressed as compared to placebo in the basal untreated state, not acromegaly, healthy state in 16 healthy volunteers. Furthermore, if oral octreotide is given to volunteers 2 hours prior to GHRH or arginine, which elicits a brisk growth hormone response, you can blunt the response significantly by the pre-treatment with oral octreotide. And these were the first indications that the oral absorption, which I showed you on the earlier cartoon, is in fact bioactive in human patients. And the first phase 3 trial published showed that in patients who were previously responsive at baseline to injectable somatostatin analog, you can see the baseline GH on the left and the baseline IGF-1 on the right. The oral octreotide switch from the first dose all the way through 13 months maintains the control of growth hormone in these 151 patients who were treated, and the IGF-1 means are controlled for a period of 13 months after switching from the injectable format. And in a subsequent paper looking at a placebo-controlled phase 3 trial, you can see that the patients have, compared to the placebo, have controlled IGF-1s and controlled growth hormones at the end of 36 weeks as compared to the exuberant burst of growth hormone or IGF-1 in acromegaly patients on placebo. There is a subsequent study which was just presented recently at the Endocrine Society in 2021 by Dr. Flecheroux that showed the results of the empowered study of oral octreotide, which showed non-inferiority when compared with the injectable. So you can see that there is an indistinguishable control of IGF-1 levels, both in terms of the output of IGF-1 as well as the number of patients controlled by either injectable in the green or the oral in the red, showing equivalence, showing actual equivalence of the injectable versus the oral. Not only was there equivalence in the study, but the patients reported improvements after switching from injectable to the oral somatostatin capsule were significant in terms of improved fatigue, swelling, treatment convenience, and treatment satisfaction. So we have all those somatostatin analogs, injectables or orals, which we can offer our patients. What happens if your patient, the one that we showed you, you've added cabergoline, you've given the patient a maximal dose of somatostatin receptor ligand, they're still not controlled. At this time, you can try Pasireotide. And Pasireotide is also a somatostatin receptor ligand, but Pasireotide works on SST5, the 5th receptor subtype. And in this power study, you can see over here that in the green, patients who are uncontrolled in the green on Octreotide, when you give them a Pasireotide, IGF-1 levels will be suppressed and growth hormone levels will be suppressed in a significant number of patients. So Pasireotide does appear to exhibit better efficacy than Octreotide or Lanreotide in any of their formulations. However, if you see on the right, Pasireotide causes hyperglycemia in terms of fasting blood sugars, in terms of hemoglobin A1Cs, and these patients will develop diabetes. So this is a problem with Pasireotide in terms of its, although it has improved efficacy, it does have the side effect profile, which is more deleterious than that of the Octreotide or Lanreotide formulations. So to summarize SRL therapy, you can see this patient here is with a large macroadenoma and acromegaly, chose to have primary treatment with a somatostatin analog. The tumor shrinks nicely. This is a beautiful representation of tumor shrinkage, but the patient developed gallstones. So although we do get rapid control and symptom relief in the majority of patients, no hypopituitarism and tumor mass is usually controlled. We don't often see such beautiful shrinkage, but the mass growth itself is controlled. These patients may develop gallstones or sludge. They get diarrhea, nausea, and abdominal discomfort. And hyperglycemia is especially important for Pasireotide. Patients develop bradycardia. And for the injectables, there's injectable site pain. These are painful deep intramuscular injections or deep subcutaneous injections, and patients may develop alopecia. Again, to emphasize, the disease cure is not permanent. It is controlled. Long-term treatment is required. There's a sustained cost. And for the non-oral availabilities, these patients require long-term injection compliance, either in your clinic or in the hospital. And this is a disadvantage for patients. So let's assuming that the patient that you're looking at, the personalized approach to your patient, has not responded to Pasireotide, has not responded to increased somatostatin receptor ligand, you can then try Pegvisomant, which is the growth hormone receptor antagonist. And Pegvisomant, to remind you, as exemplified in the yellow cartoon here, sits in the bi-arm of the bi-arm growth hormone receptor in the purple and the blue in the liver, and blocks the signaling of growth hormone on its receptor in the liver, blocking IGF-1 production. It does not act on the pituitary. And these patients, your goal is to normalize their IGF-1 levels, to control their symptoms, and overall efficacy does appear to occur in more than 70% of patients receiving 20 to 40 milligrams a day. The disadvantages, however, of Pegvisomant are, well, firstly, it doesn't target the tumor. It only targets the peripheral liver. It requires daily injection. Rarely liver enzymes may increase, and rarely lipodystrophy has been reported. However, these patients, although this is depicted beautifully in the initial studies by Peter Traynor in the New England Journal of Medicine, now 20 years ago, you can see these patients, although they suppress their IGF-1s beautifully in a dose-dependent fashion, their growth hormone levels go up because you've removed the negative feedback inhibitory control of the peripheral IGF-1 on the tumor growth hormone production. So in effect, although these growth hormone levels are high, the growth hormone is bio-inactivated because the peripheral receptor is blocked. But nevertheless, you cannot measure growth hormone as a biomarker of successful treatment because it will invariably be high in these patients. So the question is, how many patients normalize their IGF-1 levels on Pegvisomant? And we don't really know from controlled studies. All we know are the results of the surveillance, which is a non-controlled study surveying all patients receiving drugs. And this is the most recent surveillance of 1,450 patients who've been followed for 10 years in this surveillance of patients receiving Pegvisomant. Again, this is a non-controlled study, purely observational, and you can see, well, 1,400 started, and after 10 years, there are only 105 patients. We don't know how many patients dropped out. So with that caveat, it does appear that in the red, there are about 25% of all the patients being surveyed who do not respond, whose IGF-1 remains above the upper limit of normal, and about 70% of patients in the black who do respond, whose IGF-1s are reported as normal. But again, this is uncontrolled, but nevertheless, it gives you a good snapshot of what you expect in the population from your patients receiving the growth hormone receptor antagonist. So let's assume you've given Pegvisomant. At this point, what else can you do if your focused approach to your patient is not working? Well, we could offer these patients a combination of a somatostatin receptor ligand with Pegvisomant, so-called combination treatment. And we've been very intrigued by combination treatment. I want to emphasize it's not approved in the label, and it's very expensive. So we were concerned about using a combination of somatostatin receptor ligand with Pegvisomant because of its expense and the requirement for daily injections of Pegvisomant and monthly injections of somatostatin. So we performed a study, a prospective study, which was only published last year, looking at 52% of patients in whom we prospectively categorized into 3 groups. The first group receiving high-dose somatostatin plus weekly Pegvisomant, and to emphasize, that's not on the label is daily, or receiving low dose, the lowest possible dose of somatostatin receptor ligand with weekly Pegvisomant, or daily Pegvisomant with low dose somatostatin, which is what the label says. And we were surprised that looking at this controlled prospective categorization of patients, we were extremely surprised that they all normalized, regardless of the protocol, and that 96% of 52 patients uncontrolled at baseline, controlled after 6 months. Not only were they normalized on the low-dose weekly Pegvisomant and low-dose monthly somatostatin, the cost was much cheaper. $9,000 wholesale costs in the USA versus $14,000 for this group and $22,000 for this group. Clearly a major difference. So our approach today is low-dose somatostatin and weekly Pegvisomant, although it is an unapproved on the label. So the rationale behind the combination of somatostatin receptor ligand and Pegvisomant at the low dose, weekly Pegvisomant and monthly somatostatin, is to hit the liver and hit the pituitary gland, to improve morbidity, to control IGF-1 in more than 90% of patients with uncompromised pituitary function. Tumor size is indeed controlled. Adverse effects are similar as to the monotherapies, and we can avoid less safe surgical treatments like radiation or repeat second or third surgery. And at the end of the day, this is going to be a patient choice. So if we assume that the patient still is not controlled, and there are very few left at this point of the paradigm, at this point of our flow chart, there are going to be very few patients who are not controlled. At this point, we would consider radiotherapy or repeat surgery. Now let me turn to quality of life for one moment before we end. And quality of life is really important. And there was a very interesting study that Dr. Eliza Geary in New York published, which came on the heels of a similar trial, which Dr. Strasburger published in a couple of years ago. And this looked at patients, these both looked at patients' symptoms. And it turns out that on injectable somatostatin receptor ligands in the red, there are dramatic increases of symptoms: headache, excess sweating, joint pain, swelling, carpal tunnel syndrome, snoring, visual problems, and the acromegaly fog at the end of the injection cycle. The last 5-6 days of the month after the injection, the symptoms exacerbate and seem to burst through the baseline, which would be further rationale supporting an approach of giving an oral capsule twice a day to prevent the breakthrough of the waning of the effects of the long-term 28-day injection. And we don't yet know whether this will occur, but now what we're doing is we're putting patients on the oral to sustain a plateau of somatostatin throughout the month so that they don't have these breakthrough symptoms. And in order to follow these patients, don't just focus on the IGF-1, even though the personalized approach will be geared towards following the IGF-1. we have to be concerned about their overall outcome. And this patient, we have to be concerned about her headache and her arthralgias, her cardiac failure, her hypertension. Will she or won't she develop diabetes? And most importantly, to prevent sleep apnea, and if it does occur, to treat the sleep apnea. We have to be concerned about endocrine replacement if there's compressive attenuation of pituitary hormone secretion. She may want fertility. She has a lot of self-image problems and anxiety, which we have to counsel her for. She may even require maxillofacial surgery for overbite or for TMJ, or even for cosmetic purposes. We have to help her interpret laboratory testing, because all these patients go on the web, they see the results. The IGF-1 assays are not good, as you well know. Even IGF-1 assays are all over the place, and patients get very, very stressed out when they get an abnormal IGF-1 results. And most importantly, whatever therapy we offer them are going to have side effects. And as endocrinologists, it is our responsibility to help them navigate preventing side effects, and if they do develop them, to switch therapies or to alter therapies or to combine therapies to try and attenuate the impact of the side effects. So to summarize, acromegaly is a process with a chronic growth hormone excess, usually from the pituitary adenoma. Unfortunately, when we see patients, because of the delay in diagnosis, they usually have advanced disease because of chronic IGF-1 exposure. Their comorbidities may occur if they're chronically uncontrolled. And we now have an armamentarium to offer them an integrated management approach based on biomarkers, which hopefully will become more precise as our translational science moves more and more into the clinic. So thank you very much for your attention, and I'm happy to answer questions. And thank you again for inviting me to join this interesting symposium.